I graduated about 7 years ago. So this is just a little bit of an overview of some topics that I thought might be a little bit important to you guys working in AByay that you might see often. It's not an exhaustive list of speech information, but it should give you guys a little bit of an overview. Anytime throughout the presentation, if you guys have questions, please stop and ask. We can have a discussion about things. We can talk about client stuff. I might not be able to answer your questions, but I can at least attempt to point you in the right direction. I have to figure out how to navigate through this. Okay, so what are you going to learn today? I'm going to tell you what a speech language pathologist is. I'm most likely going to refer to them as SLPs through the rest of the presentation. I'm going to go over some common speech disorders in children, the anatomy of speech sounds and where they come from within your mouth, some phonological processes, and then lastly, I'll go over some information about collaboration with SLPs and BCBAs. So what is an SLP? Most SLPs do have an undergraduate degree in communication sciences and disorders. Some also have undergraduate degrees in related fields. All of them do have a master's degree. Some do have a doctorate level degree. All SLPs have a certification of clinical competence, or their CCCs. In order to get this, they have to complete their master's program, pass the praxis exam, and complete clinical fellowship hours. So it's really similar to becoming a BCBA. And they're accredited through their board, which is called ASHA, and that's the American Speech Language Hearing Association. In order to maintain their CCCs, they also have to get CEUs. They're on a 2 or 3 year cycle, just like BCBAs are on a 2-year cycle. They do have a code of ethics that they have to follow, and they also need to use evidence-based practice within their therapy. So the first section I'm going to go into is a little bit about child's speech and language. So child speech sound disorders, basically speech sound disorders is an umbrella term for referring to any difficulty or combination of difficulties with either perception, motor production, or phonological representation of speech sounds or speech segments. So there's 2 branches, there's functional and there's organic. In the functional side, you have articulation and phonology disorders. A lot of the times those are grouped together, but articulation more focuses on the physical aspect of like how you're moving your tongue and the anatomy within your mouth, where phonology is more linguistic aspects, and it's more predictable errors that happen. And then on the organic side, all of these speech sound disorders are either developmental or acquired. So motor or neurological disorders, this could be dysarthria or apraxia. So dysarthria is, I'm going to go a little bit more in depth in these on the next couple of slides. But dysarthria is like the actual physical execution of being able to say a speech sound, where apraxia is the planning from the brain to the mouth. And then you have structural disorders, so that might be a cleft or lip palate or any other oral facial anomalies that might affect a person's speech. And then any structural deficits that might be due to trauma or surgery. So if like someone has a stroke and they have facial paralysis, or if they have a surgery and they need to learn how to use that part of their mouth again. And then there's sensory or perceptual. So someone with a hearing impairment might need speech therapy. Someone with a cochlear implant might need speech therapy because of their perception of sounds. So on articulation disorders, again, articulation and phonology disorders are kind of grouped together. But articulation disorders focus on errors in production of individual speech sounds. So distortions or substitutions that someone might make in a speech sound. And it's only an articulation disorder if that problem persists beyond what is developmentally appropriate. And then with phonological disorders, these disorders are predictable, they're rule-based, and it might affect more than one sound. So this is, I'm going to go into phonological processes a little bit later, but these are errors that are happening that are predictable, and they often happen across different words with the same sounds. And phonological disorders are the way that the brain organizes and processes how you say sounds. And again, phonological disorders, like articulation disorders, they're only considered a disorder if it persists, if that problem persists beyond a typical age of development. And phonological disorders is going to be a different section in this. I'll go a little bit more in depth about the different disorders under that. So dysarthria is the condition in which the muscles that you use for speech are weak, or if you have difficulty controlling them. So this might be a neurological problem if someone has a stroke or a brain injury or a brain tumor, or facial paralysis or weakness of the throat or tongue that affects their physical speech mechanism. They might have slurred or slow speech. They might have the inability to speak louder than a whisper or speaking too softly. They might have rapid speech that's difficult to understand. They might have nasal, raspy, or strained voice. You might notice an uneven or an abnormal speech rhythm or an uneven speech volume. They might also have monotone speech or difficulty moving their tongue or facial muscles. Childhood apraxia speech is one disorder that you guys will probably come across in your lifetime working in this field. And childhood apraxia speech is a neurological speech sound disorder in where the consistency and movements underlying speech are impaired, but there's nothing wrong with your neuromuscular deficit. So there's something going on with your brain to mouth connection in that the brain struggles in planning speech movements. And some characteristics of apraxia might be inconsistent errors on consonants and vowels in repeated productions of syllables or words. There might be lengthened and disrupted transitions between sounds and syllables. So someone might have difficulty moving smoothly from one sound to the next. They might put an incorrect stress in a word. So instead of saying banana, like we normally say, they might say ba-nana. So they're putting the stress on an incorrect part of the word. They might have difficulty getting their jaws, lips, or tongues to the correct positions to make those sounds. And there might be inconsistency, so making different errors on different sounds. Making different errors when trying to say the same word a second time. So they might make an error on one word, but then when they say it again, they don't make an error on it. And they may have reduced vocabulary or difficulty with word order. Some other language disorders that speech therapists might treat are preschool language disorders, so expressive, receptive. Sometimes with our kiddos, they might be diagnosed with ASD, and then you might see like a communication delay or expressive and receptive language delay tacked onto that. They can also work with children with learning disabilities and selective mutism. And then some other medical or developmental conditions that they might address are children with ADHD, ASD, like I mentioned before, someone with a cleft lip or palate, anyone with brain injury, whether that's to one hemisphere or a traumatic brain injury due to an accident. Is there any questions on any of those common childhood speech disorders? Okay. Next, I'm going to talk a little bit about anatomy of the mouth and where sounds come from. And then once we have a basic understanding of those speech sounds, I'm going to go a little bit into phonological processes and some common errors that are made with those speech sounds. Again, I'm just brushing the surface with this, but I thought that this section would be helpful for you guys because a lot of the times we see speech sound errors made in our kids make those errors and we're not sure where they're coming from, where are those sounds made in the mouth, and is this normal, is it age appropriate? And this will give you guys a little bit of understanding so that you might be able to better explain it to an SLP and better collaborate with them. So this is basically the anatomy of speech sounds or the place of articulation. So where sounds are articulated within the mouth. So this isn't the actual, like, this part of your throat is not called the glottal area, but the sounds that come from that area are the glottal sounds. And then any sounds that are coming from this part of your mouth that you make back here are called velar sounds. Any sounds that you use your tongue to push on the roof of your mouth are called palatal sounds. I'm going to jump up over to here, and any sounds that you use your tongue to push, it's like right behind your two front teeth. There's like right where your gums start. That's the alveolar area, and you make sounds there a lot. And then there's, sorry, the post-alveolar area, which is between here and here. And that's where your tongue would hit that part of your mouth to make certain sounds. And then other sounds, bilabial sounds are sounds that you make with both your upper and lower lip. Labiodental sounds are sounds that you make with your lips and your teeth. And then dental or interdental sounds are sounds that you use your tongue in between your teeth. And next I'm going to go into some examples of that, but this is just the place where you're articulating that specific sound. Is there any questions about that? Okay. So next I'm going to combine the place of articulation with the sounds. So if you guys actually want to go through and practice this as I'm going through it, it'll be helpful to feel where your lips are, where your tongue is, where your teeth are, and where you're actually making that sound. You're going to see some funky symbols up here. That is the International Phonetic Alphabet that SLPs use. Other people use it too, but basically they do that so there's no confusion in what sound they're working on. So if you guys take this, for example, there's TH makes two different sounds. So in order to prevent confusion, they use the phonetic alphabet to transcribe what sound they might be working on. So that if someone goes from one SLP to another SLP, or they're consulting or writing a paper or whatever they may be doing, they know what specific sound they're working on. So we'll start in the front with bilabial sounds. So again, these are sounds that are made with both of your lips. So that's going to be P as in spy, B as in baby, M as in man, and W as in wood. So you can tell that you only used your lips to make those sounds. For labiodental, these are your F and V sounds. So you can feel that you used your top teeth hitting your lower lip to make that F and that V sound. And then interdental sounds are th as in thought and the as in breathe. So you can feel that your tongue went in between your teeth to make that sound. And then alveolar sounds, this is where your tongue's going to hit right where your gums start, behind your two front teeth. So T as in top, D as in dad, S as in sad, Z as in zebra, T as in butter, N as in nope, and L as in light. So your tongue hit that general area in order to make those sounds. And then the post-alveolar sounds are R as in red, Sh as in should, and Sh as in Asia. So you can kind of feel that more of the middle part of your tongue hit between the front of your mouth before you hit like the back palate. It's like that in-between space. And then the only palatal sound is y, as in yes. And you can kind of feel that the majority of your tongue when you're saying that sound hits the roof of your mouth. And then for velar sounds, these are made with like the back of your tongue and like the beginning of your throat area. So this is k as in cat, g as in go, and n as in sing. So you can feel that the back of your tongue like lifts up and almost hits the beginning of like your throat. And then glottal sounds is h as in happy and o as in uh-oh. So you can feel that you actually made that sound like way deep down in your throat. Is there any questions about that? All make sense?
Not a question,
Okay.
but I did my undergrad in speech,
Yeah.
and that would have been really helpful, that diagram.
I know, right? Is that Jen?
Yes.
Oh, I didn't know you had your undergrad in speech.
Mm-hmm.
Yeah, so speech therapists actually have to know the whole phonetic alphabet and transcribe it. Like I was actually just recently looking through some of my tests, and I had to like transcribe like my name and sentences, and be able to like functionally use it.
Yeah, they were like,
and there's a lot more that there. So go ahead.
They were almost like spelling bees. They would like tell you
Yeah.
the word
And there's a lot more that goes into how your tongue and mouth is shaped when you're making sounds, but this is the least jargony and easiest way to show you guys. Like there's different placements of your tongue. There's different ways that the air streams through your mouth that affects the way that your sounds are made. There's voice and voiceless sounds. So there's like so much more that you could go into just speech sounds. But it just gets very complicated and really, really full of jargon. So next I'm going to take some of those speech sounds that you guys just learned and go into phonological processes. So it is important to note that phonological processes is just the way that your brain is processing speech sounds. And a lot of these are normal. So when a kid is has typically developing speech, or even when one of our kids is developing speech at like a later age, some of these are still going to happen and they're within normal development. So this is a chart that represents when sounds should be typically developed. So this first group are like the early sounds. So P, M, H, N, W. Those sounds are going to start like the child should be starting to produce them by 1.5, and by 3 years of age, there should be no errors with those sounds. So we have to look at where are our kids at developmentally, what errors are they making, and is it appropriate? So if I have a 3-year-old that's, not able to say the j sound, well, that's normal. Other kids that are that age aren't able to make that j sound. So I always like to refer back to this, especially when I'm just starting out and maybe making like echoic targets. I might focus on some of these early ones first if I have an early learner. But I just like looking at this chart as a reference to be able to determine if my client should have a sound mastered, or if it's out of the norm for their developmental age, and do we need to like consult with a speech therapist and let them know what's happening or what's going on.
Maria, I actually really like this form. I have one similar. I'm wondering if it would be helpful to provide this to staff, because I have a lot of families that I've come into services and they want to work on sounds, and I'm like, that's not developmentally appropriate. The biggest ones I hear are like the R, L, S.
Yep. Yeah.
And so I'm wondering if we can provide this to staff.
Yeah, I can.
I would find this helpful. I would love it.
Yeah, I can include this in the, when I send Chris the slides for you guys, I can include the link for this one. And you can also Google it. There's a bunch of different ones. I just felt the colors looked best on this one. But there's a ton out there of different visual representations of this.
Thank you. This is very nice. I like this.
Cool. Okay, so I'm going to go over 3 phonological processes. I did pull this from the ASHA website. Also, the ASHA website has tons of resources on there. I really like it. It's really user-friendly. You can actually like type in anything you want at the top and it goes to exactly what you want to look for. And it also pulls up research articles for that as well. So the first one is assimilation. And this is when one sound becomes the same or similar to another sound in the word. Now I am going to, like the velar and nasal words, don't worry about that. That is the manner in how you're making sounds. But I didn't want to like overload you guys with vocab and jargon. The examples should be enough for you, but you guys can always go back and look at what sounds are under what category. So velar assimilation is when a non-velar sound, so remember velar sounds are toward the top of your throat and using the back of your tongue, changes to a velar sound, sorry. Yeah, velar sounds are the ones in the back of your throat. They change to a velar sound because there's another velar sound in that word. So let's look at the word tack. So you're starting in the front to ack. That CK sound is a velar sound. And because there's a velar sound in the word tack, they're replacing that T with that same velar sound. So tack turns into cack. Same thing for duck. You're starting in the front of your mouth, duck. That CK sound is a velar sound, and that's turning into, they're turning that D into a velar sound as well. So from duck, it goes to guck. So both the beginning and the end words are, beginning and end sounds are sticking in the back of your throat. Now that is developmentally appropriate until the age of 3. So that's another thing to think about with our kids. Even though they might be 3, they're not developmentally 3 years old across the board. So I think that's important to look at where their developmental language is in order to determine, is it appropriate or not. Now, nasal assimilation is when a non-nasal sound, so nasal sounds are N and M's, and nasal sounds is just basically that means it's the way that the air is flowing through your mouth and your nasal cavity. So when you're saying N or M, the air is like flowing through your nose. So that's when a non-nasal sound changes to a nasal sound because there's another nasal sound in the word. So for funny, the N sound is the nasal sound and the F is the non-nasal. But because there's a nasal sound in there, they're turning funny into money. Same thing with bunny. They're turning that, because there's an N sound, they're turning the B into an N sound. And this should be eliminated developmentally by the age of 3. Next, I'm going to go into substitution. These are some that you guys might see as well that are maybe a little bit more common. So fronting, it's pretty self-explanatory. Basically, a sound that is made in the back of the mouth is replaced with a sound that is made in the front of the mouth. So if you're saying car, that sound, C sound, is made in the back of your mouth, and they're replacing it with a sound in the front of the mouth, which is the T sound. So you're going from car to tar. Same thing for gate to date. And that should be eliminated developmentally by the age of 4. That's probably one that you guys see in early language learners. Stopping. This is, okay, so here's some jargon. This is when a fricative or an affricate is replaced with a stop sound. So just some examples of that. So instead of saying fun, they're saying pun. Instead of saying see, they're saying tea. Instead of zoo, they're saying do. Instead of very, they're saying berry. So basically, they're just like simplifying the sound that they're saying into an easier form that takes less work from your tongue and mouth to create those sounds. And each one of those sounds has a different developmental age of when it should be gone. So the F and S should be gone by age 3. where making errors on Z and V should be going by age 4, and some of those harder sounds like the ch, sh, j, and the sound, those might take a child up to age 5 to eliminate any errors on that. The next one is gliding, and this is when a liquid sound, so liquid sounds are the R and L sounds, and glides are the W and Y sound, so the W and Y sounds. This is also a common one that you guys might see. Katie, our client, does this. So basically, instead of saying rabbit, they're replacing that R with a W, so they're saying wabbit. And instead of saying that L sound in leg, they're replacing that with a W and saying weg. And this one has a pretty high age till it's developmentally inappropriate. So that's 6 or 7 age range. And then deaffrication is when an affricate is replaced with a fricative. So instead of saying chip, they might say ship. So they're still making that sound in the general area. They're just changing it to a different sound. And that should be eliminated by age 4. And then the last one I'm going to go over is syllable structure. So this is when sound changes that affect the syllable structure of a word. So if you're looking at cluster reduction, basically a consonant cluster is simplified into a single consonant. So a consonant cluster is 2 consonants together that make a sound. So ST makes a st sound. So basically they're simplifying and taking away that harder sound and simplifying it from stop to top. So they're taking apart that cluster and just simplifying it. And instead of saying clean, they're saying queen. This one is probably another one that you guys might see in kids as well. So sounds with S's, like consonant clusters with S's, that's developmentally appropriate up until the age 5, but sounds without S's should be eliminated by age 4. And then weak syllable deletion, this is also another one that you guys are going to see in early learners who are just starting to talk. So basically unstressed or weak syllables in a word is just completely deleted. So in banana, the least stressed syllable in that word is the BA sound. So they just say nana instead of banana. Same thing for potato, that PO is the least stressed syllable in the word. So they're just saying tato instead of potato. And that is developmentally appropriate until the age of 4. And then the last one is final consonant deletion. Pretty self-explanatory there. The final consonant of the word is deleted off. So instead of saying bus, they're saying buh. And instead of saying nose, they're just saying no. And instead of saying treat, they're saying tree. And that should be developmentally eliminated by the age of 3. Does anybody have questions on phonological processes?
Maria, what would...
I know that was a lot of information thrown at you.
Maria, what did you say for SC? So our client, we've been working on the word square and he adds. So I can't remember what that one's called. Would that be phonological? So he ends up saying squared.
Yeah, I think, again, I just took this off the AByay website. There's actually a lot more phonological processes, but I wanted to go over the most common ones. I can't remember if there's one that specifically adds a sound to it. I actually think I was like, there is one. So I would have to look at that about adding a sound, adding a consonant.
I feel like I remember learning about that, but it's been so long. But that's why I feel like there was something.
There is one that describes that, yeah.
Okay, thank you.
Any other questions?
Is there one also what I see a lot is kids that can do like one simple syllable, but it has to be like a certain like the sounds have to come from a certain way in like the mouth. So like they can do like hat, but not like like bat. If that makes like any sense. Like if it's like
Yeah, so there,
yeah, like certain consonant combinations, especially if they're coming from like different parts of the mouth, they can't put together in one syllable. But if it's more like and without any terminology before, I've always kind of pictured it as more like a smooth, like easy to say, like kind of one syllable sound. Does that make any sense?
yes. Yeah, so they can say HAT because it's coming from like one area of the mouth, but they can't say it because they can't say bat because it's coming from another area of the mouth. Is
Yeah.
that what you're asking?
Yeah.
My best
Maybe like
understanding
that.
of that would be that they don't have that speech sound developed yet, or the combination of the speech sound with the vowel yet. But that might be a good question for a speech therapist.
Okay. Thanks. This is great.
Yeah, I might not be able to answer all your questions.
Yeah, when we've been like collaborating with a speech therapist before, like they're saying all these things that you just covered, and I've had no idea what they've meant before. Just like when I'm talking to them and I'm talking about mans and tax, and they have no idea what I'm talking about.
Yeah. Well, that's a great transition to my next topic. So my last section, and this is I kind of want to open this part up at the end for discussion too, with people's experiences and opinions on it. So there are between speech therapists and BCBAs, we have overlapping service delivery domains, but we also have service delivery domains that don't overlap. So some of them that do overlap that we might, and this is not an extensive list, but some pre-linguistic skills. So we might both work on joint attention, play, imitation, speech production. So a speech therapist might work on actually articulating maybe where that sound is coming from, where we also work on that, but we might work on increasing speech production. Same thing with feeding disorders. A speech therapist might look at maybe the medical side of it. They can do swallowing studies and making sure that a person can swallow appropriately, where we might look at the behavioral side of it. We both can work with augmentative and alternative communication devices. We both work on receptive and expressive language and social skills. So I actually found this, I don't know if I call it a study. It was basically just a survey that a BCBA and an SLP BCBA did. And they surveyed 19 SLPs and 16 BCBAs. And they asked some open-ended questions, and then they asked some objective questions across 23 different scale areas, and what their self-reported competency of that skill area was. So it's good to note here that a competency is different than a scope of practice. So let's just say working on, I'm just going to give this example. Working on sign language might be within a scope of practice for a BCBA, but that doesn't mean that a BCBA is competent in working in sign language. Like, I couldn't work with someone who is completely deaf and uses sign language because I'm not competent in sign language. But a BCBA who is competent in that could work with a client with that. So essentially what they found from this survey was that there's areas that both BCBAs and SLPs were similarly comfortable in providing effective treatment, but there were also areas that they were very distinctively different. And essentially what they got from this was that there are benefits to collaboration and there are barriers to collaboration. So in the areas on the left-hand side, So these were areas that both BCBAs and SLPs self-reported their comfortable and competency in these areas, and there had to be an overlap of at least or less than 10% in order for them to be considered overlapping. And in these areas, they spoke about SLPs and BCBAs doing a multidisciplinary approach in a behavioral developmental model. So in that way, basically both the BCBA and SLP are competent in that area. So you guys should be working on similar goals. You guys should have similar outcomes for those goals. So let's just say a manding goal. If both SLPs and BCBAs are competent in communication, then maybe they should collaborate on a manding goal and have the same outcomes of that manding goal and not have different expectations for the client. Where on the right-hand side, you guys see the vast discrepancies between competency in those areas, and that's okay. SLPs aren't trained on behavior reduction procedures and discrete trial training and reinforcement or preference assessments. But what they were speaking to in that area is that it shows that we can complement each other, and they talked about doing more of a teaching and sharing model. So you don't want to force collaboration on those because you're talking about people with different competency areas. So you wouldn't want to force a collaboration when it's not going to have the same outcome because they don't have the same competency. So like take speech articulation, for example. As BCBAs, yeah, we have a COIC goals, but we might not always have goals that say the client will make the D sound in the initial position for this many days, so and so. So what we might have is a speech therapist. We might be able to work with them and have them teach and share with us and how to increase that speech sound with our clients. Where on the other hand, let's just say I have a behavior plan for a kid, and I want to make sure that that behavior plan is done in all environments. So I might ask to meet with a speech therapist, go to the session, show them the behavior plan, show them a little bit about like reinforcement, taking breaks, you know, ignoring inappropriate behaviors, redirection, all of those AByay principles that we use, we can teach and share with them. So also from that survey, they found benefits and barriers to collaboration. So first I'm going to go over the benefits, and these are the benefits that are reported by the SLPs. And they reported that they had an increased understanding of reinforcement, behavior management techniques, motivation, assessments that we commonly use, data collection. They had better understanding of errorless learning and discrete trial training. And someone also reported that they had better understanding of creating a therapy plan that can be understood by everybody. And then also consistent and holistic therapy. And what they mean by that is that we just, within AByay therapy, we work on multiple skill areas, not just one small skill area. And then benefits reported by BCBAs were increased understanding of language development, early language learners, terminology, articulation, speech techniques, speech sound development, oral motor development, a better understanding of AAC and PECS, a better understanding of social language skills, feeding skills, any physical speech barriers or medical issues that might be affecting someone's speech. And then also they benefited from being able to share research in verbal behavior and support for communication strategies. So that's all great, but there's always going to be barriers to collaboration. Again, these are self-reported by just like a small group. It was not a large survey. So some barriers that were reported by the SLPs were overlapping outcomes. And I think what they mean by that is lack of overlapping outcomes. They didn't have the opportunity to work with BCBAs in their current environment. There was a lack of communication. And then someone also reported that the disciplines differ greatly in professional training and underlying methodology. So that's an interesting one because we have a huge overlapping area of skills that we both work on, yet we're both trained very, very differently. And I can attest to that a little bit with having an undergrad in speech and a master's in AByay. There are similarities, but it is different. Some barriers reported by BCBAs were turf, not aligning goals. They reported that there was scheduling, time constraints, availability, financial limitations, insurance coverage, an unwillingness to collaborate, a lack of knowledge or respect for AByay principles overall, reduced use of evidence-based therapy techniques, different beliefs regarding sensory, so sensory issues or sensory integration, data collection, so the way that we collect data is different, and rigidity in philosophies versus translating what the other discipline is doing into how you can view it within your own discipline. So basically what that means is that being so rigid in your own discipline that you can't explain what you're doing in layman's terms or want to explain it in order for the other person to translate it into their own version within their own practice. And then decreased parental willingness to allow for collaboration between two professions. So some overall recommendations for collaboration. This was actually taken from a presentation that was done at an ASHA convention, I think. And one of the main people that are actually like have papers that this is based off of was my professor at Westchester, and she was actually an SLP BCBA, and I actually had no idea she was a BCBA at the time because I had no idea what a BCBA was. But anyways, they recommend to acknowledge the problem. So if you're collaborating with a speech language, an SLP, and there's a problem, like let's just acknowledge it, not just say like, let's move on and forget about it. Understanding each other's scope of practice, I think that's a big one. There were other recommendations to read each other's journal articles and understand a little bit more about each profession. Acknowledge each other's strengths and limitations. Leave any baggage at the door. So if you've had a bad experience with a speech therapist in the past, don't let that affect someone else that you're collaborating with. Complement and collaborate each other and collaborate with each other. Engage in lifelong learning, so read journal articles, go to conferences. I know I went to the Penn State Autism Conference a couple years ago, and I made sure to get into some speech, some people that were like SLPs that were doing speeches and presentations so that I could educate myself on that a little bit more. Participate in national advocacy. I'm actually part of a Facebook group, and I can share that with you guys in the email too. It's an SLP AByay special interest group, and it's actually run by an SLP BCBA. And they always post like really good articles. I get a lot of I feel like I get a lot of like good overall communication articles from that area. From that group, and then advocate for our families. When it comes down to it, our families are the most important part. Like they're the ones that we need to benefit from this collaboration. If we're not advocating for our families and doing the best that we can when we're collaborating with speech therapists, then are we really doing the best that we can for those families? So that's all I had, but I kind of wanted to open it up for discussion of anybody that's like had a good collaboration or bad experience with speech therapists. What are your opinions of speech therapists? Has anybody had like any experiences that they want to talk about?
I know Melanie Melanie and Libby were on a case where they were collaborating with a speech therapist and incorporating their recommendations in what we're doing. If you guys want to talk about that for a minute.
Yeah, Libby, are you also here?
Yep, I'm here.
Okay, cool. So the kiddo that we were collaborating with was he has severe apraxia. Really hasn't said a lot of sounds. Prior to starting with us, would babble and stuff like that. But we started working with him on vocals, and we were really close with the speech therapist, looking at what was developmentally appropriate. We're also using the device, and I have to say the speech therapist has been awesome because we've had a lot of questions. And it's been really kind of fun because we're taking, we're looking at it from the AByay side, and she's, from the speech side. And I think honestly, like, we've had a really good experience in that she's been able to explain why she's doing what she's doing, and we're able to explain why we think we should be doing what with the device. Obviously, I think the speech therapist is a bit more of an expert than I am on the device. But it's been a really good experience. Honestly, I've never had such a good experience with a speech therapist. I've had some not so great experiences, but this one has been really good. And our kiddo is actually using the device functionally. And Libby can attest to this. Several times now, he's had 4 back and forth conversations with her using the device. And I don't think we would be where we are without a good speech therapist. So it's been really good.
Yeah, I really like our speech therapist. She is very willing to work with us. Like, she really gets where we're coming from on our side, and although she may not always agree with it, she definitely lets us go, gives me ideas on, okay, well, I know you do it this way, but think about this way too. Like, she's very accommodating. She's very understanding. Like, it has been a wonderful experience for me as well, because you know how I love technology. So.
Yeah. Honestly, we can like disagree, but we can agree to disagree with a speech therapist, and we can find that middle ground, which is awesome.
Yeah, I find in my last job, the county that I worked in, all of my kids were in like the public preschool, and a majority of them had an AAC device because the school like was really good about handing them out. And basically, speech therapists and BCBAs teach those devices very, very differently. A lot of speech therapists focus on core words like more and give and yes, no, or, where we focus on what they're called like fringe words. We want a kid to label more items and actually request the specific item that they're asking for. So that can be a big difficulty in being able to collaborate on that too. And I also had a kid on a speech device, and they introduced it, and I was kind of taking the SLP's lead on it. And we started out at 1 word, and it was going great. We were able to add like all of his reinforcers into a certain category of it, and he was like using it a lot. And then she jumped too quick to 2 words, and we were taking data on like his use of frequency and rate of using it, and it decreased drastically. And I had data, and I showed mom, and I was like, we're going back to 1 word request until we get a little bit more increase in that. And the speech therapist was fine with it. She said, okay, like if that's what you need to do for that client, for your kid, then that's what you need to do. But we are taught and think a lot differently in how we do things and how we teach things.
Yeah, absolutely. A lot of times we categorize everything as well. Like, we're taught from the very beginning, everything's categorized, everything has its spot, and it doesn't kind of work like that with these devices. So I struggle myself in trying to find where things should be and where they should actually go on the device, because it is a lot different thinking. You're right about that.
What program is your client using on the device?
It's a lamp.
The lamp. LAMP program?
Oh yeah, LAMP's fun. I actually, like, all of my kids had LAMP at my last job, and my techs would be like, "How do I teach it?" And I was like, honestly, it's basically the speech therapist said it's all muscle memory.
Yes.
So you
Yeah.
memorize where they are. And I was like, I can only help you. So like I would actually sit there during my supervisions, and when the client wasn't using it, I would like take it and go through it and practice it myself. Because
Yeah,
it's
I
hard to
have to
teach
take it
it.
home because it doesn't make sense where some of the things are. It's kind of crazy.
Yeah, I actually and then I made cheat code. I made like a cheat sheet for my techs. So I put like common things that they used. I like wrote like frog, the whatever's under the frog icon. If they
It's like
needed
go.
something, yeah, if they needed something under that, I would write like frog icon and then what are common things that the client requests under that. So like a little cheat sheet that they could just like have throughout the day in order to like,
That's a good idea. That's a really good idea.
yeah, because like the client's like trying to request something and you're like, oh, where is it? And like this, by the time you figure out where it's at to model it to them, then their motivation's gone.
Absolutely.
So that might be helpful.
That is,
Yeah,
thank you.
that's a really good idea. I will say what has also helped our kiddo, Libby, so we had a nice transition because this is a kiddo we use pictures for, and until we got like a 3-inch binder that couldn't possibly fit another picture in. There were hundreds of pictures and he would actually use it. The speech therapist actually helped us make a nice transition from that book to the device, which I think was also instrumental in his success. But also Libby will use the device to speak with Mason so that he sees that she understands how to use it as well. And it's also helped for her to teach him because she is like more fluent in it, if you will, using the device. So I think it's been a wonderful collaboration. It really has been.
Yeah, that's good to hear. LAMP's been like a pain in my side for the last couple of years, a little bit, but as I got to know it better and understand it, I think when I first was introduced to it, I was like, how do kids even learn off of this? Like, it doesn't make sense to me. How is a kid going to understand it? But I think the more that you understand how it works, I think you're better able to appreciate it and teach a child how to use it.
Mm-hmm.
It's definitely getting easier for me. It's a lot easier now.
And with this client too, when we were first getting started, there was a lot of collaboration on the sounds that we were targeting. So the speech therapist did the assessments and picked a few sounds to target and gave mom homework. And then we were also trying to target words that had those sounds in them too. I remember the speech therapist going uh, the word mom as a word, and she would go like do this certain thing with our client's lips to try and get him to make that sound, mom, and that expertise was able to help us in picking our targets also.
Yeah,
so
definitely with the touch prompts.
And that's different. The different speech therapist, that was the outside speech therapist, so she does more touching of the face. The speech therapist that is helping us with the device is the school speech therapist, and she actually uses the hand signals as speech prompts, and the outside speech therapist was using actually touching the face and touching the neck at the certain spots where the sounds were supposed to make. So I've actually learned both sides, which is really neat because I can use it on his face and then also use the hand signals that he's familiar with school as well. So I really like both of them, actually.
Yeah, that's true. I forgot about Anne. Yeah, the school one is the one with the device. Yeah, and honestly, I forgot about Anne because we haven't seen her in a while with everything going on. But both of those speech therapists are amazing. We got lucky, I think.
Yeah, that's good. That's awesome.
But
does anybody else have any questions or like topics that weren't covered that you might like want covered? Anything like that?
I did have one question, Maria, specifically with regards to a kiddo that may be tongue-tied, or, you know, you hear these terms. I'm not really super familiar with this. How does that affect speech? And
Like having a tongue tie?
yeah.
I have no idea. That's out of my
Okay.
competency.
Okay. I'm just kind of curious because we have a situation with a particular kiddo that I guess may have one.
Melanie.
Mm-hmm.
So I worked with a kid at Children and Youth who was tongue tied at birth, had his tongue clipped, and when I worked with him, he was 4, and he had childhood apraxia. So he had a lot of noises but no actual words.
Mm-hmm.
And I got him into Schreiber for speech.
Okay. And that helped?
I don't know. I had to transfer the case at that point, so I'm not really sure.
Okay.
But
I guess I'm
did
just
have-
wondering, do those kiddos like catch up then to their same age peers once
Yeah.
that's corrected medically?
Yeah, I wasn't with the case long enough to know the
I would
outcome.
think so. If you're working on it and you're getting speech therapy, that they would then, like, they might be like later in their developmental milestones with speech, but I would think that they would still acquire speech as long as the tongue tie sticks and doesn't. My sister, actually, all 3 of her kids have had lip ties or tongue ties. Now she got them clipped more with like childhood, like infant feeding stuff, but they can fuse back sometimes. But I'd be interested to see how tongue ties affect speech, though.
Anybody else have anything they want to talk about related to speech? All right, Maria, any parting words?
Nope, that's about it. If anybody has any questions about anything, you can contact me. I can point you in some resources. The ASHA website is really resourceful. And that Facebook group is actually the articles that the person who runs it shares are really beneficial. And they also discuss a lot of collaboration between SLPs and BCBAs, whether it's good or bad. So.
All right. Well, thank you very much, Maria. This was awesome and super informative. I really appreciate you tackling this topic for us. So
No problem.
that's the end of the training. Thank you, everybody, for attending. Next week, we'll do the Maria and Melanie breakout staff meetings again. So I'll send you all invites then next week for that. Maria at 5 and Melanie at 6. All right. Thank you, everybody. Have a great night.